Is there advice that you would give to us as ER
That's a
providers?
good question. I think I've given a lot of thought to that because it's a weird role being a PA or an NP in the ER when your education levels often, I mean, NPs, they can get online, PA school's 27 months, and it's not focused on emergency medicine. You cover a lot of it, but it's very geared towards primary care for the most part. You're learning much more in depth how to manage chronic illness as opposed to acute. And so I think for me, and you adapt to the physician you're working with in a lot of ways. For me personally, and some of the physicians I work with will say you shouldn't adapt your practice, or you just do the same thing the way you normally do it, but you do adapt to some degree with who you're working with. And I think being adaptable as a mid-level provider is really important to the workflow of the department. If I'm working with someone I think is more apt to order the CT scan, I will adapt and order more CAT scans. And if I'm working with someone that's more of a minimalist, I know if I order the CAT scan, they're going to cancel it. So I won't order. And you can only do that to a degree. You can't adapt completely to everybody. You're going to work with physicians that are much more similar to you and some that are very different than you. And so I think being adaptable is a big point. And also understanding that I don't fight the physicians if they want to order something. Like I think, and they have that same perspective with me. If I think they need to order a D-dimer, they will often not say we don't need to do that, but I see us as complementary, I think, to the physician when we're working as a team. And there's a whole score of patients that I'm comfortable seeing and treating without a physician. But I think understanding that point where you need to have a physician involved is a hard point to get to and requires a few years of experience before you're comfortable with. I think I'm kind of rambling on just different perspectives I have on that team mentality, but when you're a new APP, being humble and teachable, I think is very important. Regardless of your background before, you need to come across as teachable and humble so that the physicians have the freedom to speak into your workflow and your practice. Because if you come across as, I know everything, like I was a paramedic before, I've seen it all, and they don't have that freedom to speak to your practice, I think that's a dangerous place to be in, because nobody knows it all. And I mean, I learn new things every single day. I see conditions often every week that I've never even treated before. And the physicians too. I mean, we are all constantly learning, and you have to be willing to learn, I think, to be successful as a PA or an NP. And realizing that, the physician you're working with did a full residency. They've probably done this procedure hundreds of times that you've only done a couple times. Like, ask them if you're uncomfortable. Don't jump into something you're super uncomfortable with. Have them hold your hand if you haven't done a central line before. You don't need to jump in acting super confident when the confidence really isn't there. And maybe you're very confident with certain procedures, but I think just being open about that kind of stuff is really important. And just having that affect that allows people to speak into your practice and be like, hey, Aaron, you didn't order this on this patient. It's pretty standard to order this test on this patient's presentation, because sometimes you wouldn't know unless somebody told you, if I'm working in the triage department and I'm forgetting to order pregnancy tests on women with abdominal pain and no one says anything, I would probably go off that shift and be like, oh man, I forgot something that's very standard to order on that. And, sometimes I'll miss a couple and the physician will be like, hey, Aaron, you're not ordering pregnancy tests on a bunch of these people. And you're like, oh, sorry, I was moving really fast. And, you don't see your blind spots. And so you have to have an affect that allows people to speak to your blind spots, or you'll stay blind in those areas. So I think especially as a new APP, you have to be adaptable. You have to be humble and teachable. You can be confident in certain areas, but you have to allow people to speak into your practice, I think. Maybe that's a long-winded way to answer your question, but that's kind of the big things, I think. And even after doing it for 6 years, I'm much more confident in the patients that I can treat this patient, be very confident I'm not missing anything, and discharge them without having a physician. But there's a whole bunch of patient-specific complaints and age groups where even if I'm confident I did the right workup, I'm still going to have a physician see them to make sure I'm not missing something on a patient that's high risk, and make sure I get their opinion before I decide they're safe to discharge.
And I think that garners you a lot of respect too. I mean, I remember one of the nurses who had made a mistake, who approached Marilyn Gifford about it, was very afraid because of Marilyn's reputation. And Marilyn said, okay, now I know I can trust you.
Yeah.
Because you came to me with a mistake or a question, now I know I can trust you. So
yeah. And there's so many scenarios that are like that, where you get this weird CT scan read and, it's kind of 50-50. This might be all chronic stuff and they can go home, but I would like a physician to look at this and say, right, do I need to call surgeon? Cause I mean, that's a genuine question I probably have at least a couple times a month is, what's going on with this CT read? Does this mean I need to call a surgeon, or is this someone that can go home? And I truly don't know. And, and even physicians struggle with that too. And usually the answer in a lot of these scenarios is you should consult the specialist. If you're not 100% on something, usually if I'm questioning, should I or should I not consult the specialist, usually the answer I get when I talk to a physician is, let's consult the specialist. You can't really go wrong by choosing that answer. And I don't know why that wasn't something that came to my mind early in my career, was if I'm in doubt, consult the specialist. I don't know why that took a long time to pop into my head, but that's usually the right answer. I think that's good advice for new people, is just consult the specialist, because...
So there was a famous quote about that they used to say at Copic, but you can't say it anymore, which is never carry a coffin by yourself, so.
Yeah, it still holds true. And it's... and often if I have to talk to a physician about a patient I'm worried about because of a weird CT scan read or a weird presentation, that's almost always the answer is, this is odd. You're right. Let's consult the specialist. And especially now, I'm sure that's differed in your practice over the decades, is there's a specialist for every condition now. Medicine's very specialized. And so we shouldn't just always trust our own instincts on when consultants are very easy usually to get a hold of, especially during the day. Yeah. And that's what they're there for, is to consult on patients that they're the expert on. We're kind of we have to be the second best specialist in everything. Right. But if we're worried about a specific thing, they're the expert in that,
I love the electronic messaging that we have available in Epic, because I think that makes it so much easier for everybody involved. You can say, hey, funny CT reading on this. What do you think? And, half the time I'm surprised by the stuff that they really do want to follow up with, that I think is probably an incidental finding. So that's good. It's also nice to be able to message the radiologist and say, is this really something brand new?
Yeah.
And
it makes that barrier just a little bit smaller, because even when I first started, it was phone calls to everybody. And, if you have a pending phone call, you don't want to be too far from your computer when they call back. You don't want to be in the bathroom when, so you're constantly a little bit on edge, like waiting for that phone call, knowing that if you're going to go get a report from an EMS crew, they might call and you're going to get interrupted, versus chatting them on a messaging service. It's out of your brain. You can go do a bunch of things. You can go use the bathroom. You can go see a new patient, come back to the computer, and you may have a response, but you're not waiting on that phone call. So even just that little decrease in barrier to the consultants is, I think, super helpful.
Yeah. Well, it used to be that you'd have, 3 admissions and you'd have to wait for each person to call back. And now you don't have to do that. But yeah. But then the other part of it, you're talking about change in practice. Like, we used to be down the hallway from the radiologists. And so if I had a question on an X-ray, they would bring the X-rays to us, right? And you'd put it up on the box, and at nighttime they would overread it the next morning sometimes. But you could go down and say, hey, Dr. So-and-so, what do you think about this? And so that was a little bit better, because they could just teach you so much.
Yeah.
You could just go up and they'd say, no, this is actually, overlying shadows, and this is this. And so that was actually a fun thing that I miss.
Yeah. I imagine you learn a lot that way, having the radiologist point to things. Cause that's, those days are kind of gone where they can point to things. Yeah. And, yeah, usually my questions to them are, this looks a little goofy here. Did you see anything there? And the answer is kind of yes and no. They can't really go into a bunch of text explanation of why they interpreted it the way they did. And being able to read your own imaging. And I mean, that's still something I actively work on, is my ability to read a CT scan. And fortunately, it's not 100% on us ever to read our own x-rays or CAT scans. Because again, there's a specialist for that. And if you decide something's totally normal and they decide differently, you're on the hook if you discharge that patient and you've got to call them back or whatever. So it is a little bit of a relief to have a specialist even for that stuff. When you look back on your career, what's the stuff you're most proud of?
I think a lot of it's the connections. One of the things that people say when they retire is they miss, the kind of casual connections. And there's a Facebook group of all the people that used to work in the ER, that are still together. And I mean, you do kind of miss those connections and those people. But yeah, I mean, I think I'm proud of treating people the way that I would want to be treated. I grew up in this town. I took care of a lot of my friends' parents. And I felt good about it. I felt like I did a good job for them.
Yeah, I think just can't go wrong if you treat people the way you want to be treated. I mean, the golden rule, right? It's, if you're not cutting people off, you're giving them time to ask questions, having good bedside manner, sitting at their bedside. That is the stuff I find the most rewarding. And it's something that in the ER with our volume, you have to actively seek, or
you can't do always.
Yeah.
It's hard. Yeah.
I've even, heard that, if you can just do that with a couple patients throughout the day that kind of need that time to process things or whatever. Because certainly we don't have the time to sit down and talk with every single patient for 15 minutes. But those do seem to be the most rewarding, where even if it's not, we didn't find anything emergent, we didn't do anything that saved their life, but taking the time to reassure them and talk through their workup, why we did what we did, can be really rewarding, and then makes their visit a lot more satisfying when we don't have a clear answer, which is something we struggle with a lot in the ER. Is a lot of times we get a bunch of negative tests and I don't have a clear cause other than to say it's not something that's going to kill you, and I'm very confident you can follow up with your primary care. And that's kind of a hard conversation to have with people when you're not giving them a clear answer, and you have to explain why we as emergency providers are okay with not getting a clear answer in this circumstance. Because so much of what we're doing is ruling out the dangerous stuff. And we've done that, but I'm not sure why you're hurting, Yeah.
And I think, especially for something like abdominal pain, where we don't usually have a diagnosis, what I learned early on was just to set the stage of, we come up with the answers on maybe 10%, and those are the people that need to go to the operating room, and you probably don't want to be that 10%, so because sometimes people would be enraged that they would have been there waiting for their CAT scan results for hours, and then we don't have an answer. And so I think sometimes just setting the stage and saying, I hope we don't find what I'm looking for. I hope you don't have what I'm looking for.
That's a great line. Yeah, I think setting the stage is something that's good advice for new people. Is when you first see the patient, kind of give them the right expectation about what to expect for this visit. Because that is true. 10% of the time we find a bad answer. Hopefully that's not the case for you. Right. But that also means we probably won't have a clear answer, and that way they do have the right expectation, and they're not sitting in a room for 4 hours with the wrong expectation that we're going to get a clear answer every single time. Right.
And saying, to the people that come in with especially chest pain, that we don't end up with an answer, and they're kind of embarrassed at the end. And I have to say, I'd rather see 400 people and it's not a heart attack than have somebody sit at home, with a heart attack and die. And so, I think just reframing some of those things.
Yeah. The chest pain's a big one. And I always tell them the same thing, because they are kind of embarrassed at the end of a 3-hour ER visit that they're not having something emergent going on. And they're like, oh, I shouldn't have even come. And I'm like, no, if you were my family member, I would have told you to come to the ER, because Chest pain is not something to write off. And now we have all this objective data that says it's not a heart attack and, your risk factors are low. We know it's not a blood clot or a punctured lung. But until I've gotten all this information on you, I couldn't have just told you that over the phone. So you needed to come in. It's not a waste of time just because it's not something that's harming you. Now you have that reassurance. And
yeah. And the first probably 10 years of my practice, the people would call into their family practice docs and they would get not evidence-based phone triage, but they would get a phone triage from their primary care or the nurse. And there were some really bad outcomes. And that's why you can't go to urgent care and say you have chest pain and have them keep you there.
Yeah.
You can't call into your primary care office for an appointment with chest pain. They won't see you because there were a lot of people that had bad outcomes. So, I just keep that in the back of my mind as well for people, kind of remind them of.
Yeah, honing that kind of phone triage system because you can look through and, you read the note on, here was the phone conversation they had with a nurse and they said chest pain, they said shortness of breath, whatever it is. And there's only one way that goes. It's you need to go to the ER. Don't bother going to urgent care most of the time. Go to the ER. But I like being that catch-all for people, even when it's just reassurance and a negative workup, because we do catch it when it's a young person that is having an MI and your gestalt would probably never say, statistically, you probably don't need to go to the ER, but because there's protocols in place, we catch these emergent things and they happen with, some level of frequency. And so you genuinely make a difference with keeping to certain protocols, I think, in those settings.
Yeah. And learning from other people's, experiences and mistakes is good too,
Yeah. Well, as we kind of wrap up, is there any lessons that you've learned over the last 40 years you think would be good to convey to people?
Always go to the bathroom when you hear a level 1 trauma coming in. No, I think, that's serious, but I think, that we've pretty much covered it. Hydration and food is really important, though. I think that a lot of times we miss meeting our own needs, and then we wonder why at the end of the day, we're getting a little bit grouchy. So make sure you do those things when you can, when you have a chance.
Yeah, I tell people, take care of yourself before you take care of the patients. Yeah. And truly, you say it jokingly, but you can't think as well with a full bladder as you can if you've been able to empty your bladder. And that's something I've learned too, is if I hear a full trauma is 5 minutes out, I'm like, yes, I can go use the bathroom before I'm in a room for a half an hour, because you are going to think better and you're not going to be thinking about your full bladder the whole time. And if you're getting to the end of a shift and you haven't hydrated, you haven't fed yourself, you haven't had proper nutrition, that affects your ability to think clearly and you're just thinking about food or whatever it is, you're becoming hypoglycemic. Doing those little things for yourself, because they don't take long. It doesn't take long to hydrate. It doesn't take that much time to heat up some food and eat while you're at your computer, whatever it is. And those things are important because you see people every day that they're like, I haven't used the bathroom in 3 hours. You're like, you've got some time. With few exceptions, there's time for you to go to the bathroom right now. Take care of yourself. Go fill up your water bottle. Those things are very small and easy to do, so they get overlooked. But especially as you get towards the end of your shift, when your brain is fried, that little bit of help for your brain is really important to make the right decisions and think through cases.
Yeah, 100%.
Is there anything, this is a pretty general question, but with the next generation of emergency clinicians going forward, how do you see them kind of carrying forward emergency medicine and the 40 years of experience you have? What do you kind of hope they carry forward into this next generation of medicine?
So I hope they really carry forward the observation part of medicine, because I think that that's something that can be lost in technology, is when you walk into a room, what do you see about the patient? What do you smell? Do they have ketones? Are they incontinent? What visual and non-visual cues do you get? And what's your gestalt about somebody? Because I think that there's going to be increasing reliance on technology, either the AI decision points or radiology or other studies. And then going back to the history, and it's very difficult to get a history from a lot of our patients. A lot of our patients do not have the elevator speech down. They can't tell you in 90 seconds, why are you here? Yeah. So I really think being able to hone those skills and then keep that critical decision-making component of it, like what's the most likely thing this is? What's the worst thing it could be? How am I going to discern? Is there something that I need to do now? Is there something I need to not do now? Because I think that our world is pulling us away from critical decision-making and from observation.
Yeah. Yeah, in a lot of ways, AI takes that in so many different realms of life. They take away that ability to critically think. Mm-hmm. I think that's a really good point about really assessing your patient. And then, in the history, hearing all the things that are not being said. Mm-hmm. AI only hears the things that are being said, whereas you're in the room, mm-hmm. you can see where the patient's maybe hesitating, all the nonverbal clues, because AI is acting off of only verbal clues, right? And that may or may not be accurate with patients. And I think sometimes seeing where the hesitation is, the things they don't say, the weird way they look at their family member, mm-hmm. The way they defer to their family member to answer all the questions. I mean, there can be a lot of clues. And I think that's something that only comes from a career of honing your gestalt. And I don't know that AI will ever take away your gestalt on a patient. Mm-hmm. And I've heard it both ways. Like, you shouldn't rely on your gestalt. And sometimes your gestalt can lead you astray too, and you investigate something that doesn't actually come to fruition. Mm-hmm. So even like having a little bit of humbleness about your own gestalt, I think after 40 years in medicine, you can rely pretty heavily on that. But, I think I tell that to the new EMTs and paramedics, like, you really don't have a gestalt. You haven't seen enough patients to, you need to see thousands and thousands of patients, I think, before you can trust yourself enough to do that. And even with that, mm-hmm. trust but verify, because, if you don't get that objective test that says one way or the other, even your gestalt can lead you astray. Mm-hmm. I imagine it happens less in a long career, but, patients surprise us still. You go to discharge them and something has completely changed that you didn't see when they first came in. So even 100% trusting yourself does not work every time, even when you've seen thousands of patients. So I think, but I don't know that AI will ever really take that. Mm-hmm. Because and I guess if, it's video AI and they're videotaping the whole interaction and extrapolating the data or something like that, I think it'll be a long time before mm-hmm. AI is good enough at that kind of stuff to take any kind of gestalt. And especially for now where it's verbal information that they're getting only. Mm-hmm. I think you just have to make sure you still assess your patient. You still look at your patient. You still feel their abdomen, listen to their lung sounds, and really look at them for all the nonverbal stuff that's not coming out in the story.
Oh, I have my other quote that I wanted to share, which is, now the nurses are undressing patients, but I tell people to cover up whatever part of the body they want me to miss a diagnosis in, because, sometimes people say, well, I have ankle pain, well, could you take your sock off? Well, I'd rather not. Like, well, okay. Yeah. But I won't have that information. Yeah. And, 80% of the time you don't really need it, but 20% of the time it's a big difference.
No, that's a great point, because I think we can so easily miss something. And that's what I tell patients that are like, I don't want to take my sock off or whatever. Like, I tell them, like, I'd be a bad ER provider if I did not look at the body part that is hurting you.
Right.
I can't feel everything, see everything through a sock. I need to take it off so I can make sure there's no infection or something that I would miss through your sock.
Yeah.
And that's an easy piece of information that probably gets missed a fair amount, is have we undressed the patient to an adequate amount that we can assess where they're hurting, and above and below, right? And make sure you're not missing something. Yeah, that's a good piece of advice.
Yeah.
Is there any advice you would give your younger self when you were brand new to emergency medicine?
Yeah, I think it would just be to not let people drag you down. Because I think that we live in a society where it's kind of top down, bottom up on a lot of things. And I think that some people feel good about themselves by making other people feel bad. And I would just advise myself to just not take on any of their judgment, because it's probably not about me.
That's really good. Yeah. Yeah, I've learned that lesson a bunch of times in just my 6 years in the ER. Is there are people that want to flex their ego and show how they know more than you. And I think if you can let that roll off of you, that's much more helpful than going home and thinking about it the whole time you're driving home. And because I can think of situations where a surgeon, right, like pretty close to the top of the food chain in the ER, reamed me out about something. And like, I was a brand new PA, and I'm like, I'm sorry, my report wasn't the best, but you could have come to me and said, hey, like next time you give me a report on a patient, here's the stuff I care about and how you could have made this better. And when they choose to not do that in a tactful way, it speaks much more about them than it does about you. And, depending on your personality, you might take that very personal and think about it for days or weeks afterwards and feel bad about yourself. But you're absolutely right. It speaks much more about the person doing that than it does about the person receiving it. And I try to remember that anytime I have constructive criticism for anybody. It's like, you need to do this in a tactful, humble manner, knowing that you don't know everything, and teach instead of criticize. That's a really good point. You have to let that stuff roll off of you, I think.
And I think that when you approach people in a more collegial manner, sometimes they're not open to the feedback to start with, like you were talking about, when you're EMS. But I've actually had people come back to me later and say, was that a bad miss? I'm like, I would have done an EKG on this patient,
Yeah.
Was that a bad miss? Yeah. But I'm glad you came and asked about it, and this is why, and
and they'll never forget that again, which just makes them a better provider. So there's a huge role for the constructive criticism, but I've seen you do that on shift. Your affect is in a way that people will receive it, and it's hard to do that, and I can only imagine that's the number of years you've been doing this. How to talk to somebody without making them feel judged and criticized. And therefore, they're a better provider the next day because they were able to learn something when maybe a newer ER doc wouldn't even say anything, or they would do so in a bad way. Because, usually there's something accurate in whatever the criticism is. I'm sure there was a ton of accuracies that reamed me about a patient. But I wasn't going to learn any of that because I was so indignant and mad about it and hurt, my feelings were hurt as a result. So I'm not going to learn anything in that scenario, versus if he had come and explained calmly and in a good affect, I could have learned a whole bunch of stuff, but that opportunity is missed when you don't approach it in the right way, I think. Well, thank you so much for your time, Julie. Is there anything else you wanted to say that we didn't get to? Or
I don't think so. I mean, you had a great set of questions, so I really appreciate that. Yeah.
Awesome. Well, thanks for your time. Appreciate it.